Broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. I hope you can hear me. This is Cindy Hansen from My Outcomes, and it is my pleasure to introduce Dr. Jacqueline Sparks, who is going to give us this presentation on Just Talk PCOMs as political action. And I think, Jackie, we said, maybe 40, 45 minutes for the presentation. And then afterwards, we're going to take a few questions. There's a chat function on your control panel. You can put your questions in there. Okay, Jacqueline, are you ready? You want to take it away?
Sure. Thanks a lot, Cindy.
You're welcome.
I really appreciate that you've given me this chance to speak about this topic that I've been thinking about for a number of years now. And I think it's one that represents a fundamental shift in the practice of psychotherapy. And it's based on this notion that psychotherapy is political, and it requires that we consider it from that perspective, especially its effects and how to make it just. So that's really what this talk is about. But to set the stage a little bit, what I would like to invite everyone to do is just for the duration of this talk to suspend your certainty about, just about everything, things that you just take for granted every day, and we're not aware of how these things operate. And sometimes these taken for granted things operate in ways that are counter to the values that we hold close. So if you could just entertain what Kenneth Gergen calls radical doubt about those things that are just assumed to be facts and truth, I think that will help you understand what I'm trying to say here a little bit better. So anyway, as I was saying, I'm talking about all of us here that are attending this and people who do this work. If you think back on why you got into the field, my guess is that none of you were seeking money, fame, power, and stardom. If you were, you've probably been wondering when those things were going to happen. Most likely, however, it's the fact that most of you are doing this work because you want to help people. And that's precisely what a major study by Orlinsky and Ronstadt found when they looked at 1,100 providers over 20 years. And they discovered that people who do this work were on a quest to make a meaningful difference in the lives of those that they serve. It was more of a calling rather than some kind of rags to riches quest. Oh, no. So the good news is the work that we do provides benefit for many people, and many of you have heard this, that the average treated person is better off than 80% of those that are not treated. But there's some bad news here, and this is that many people who come from non-dominant groups in our particular society, who represent ethnically and culturally diverse populations, diverse sexual orientations, people who are economically disadvantaged, come from diverse religious or spiritual backgrounds. These people either stay away from psychotherapy, or when they are required to come in, they simply do not engage in our services. And many clients do not find what they're looking for, and they drop out. And this is particularly true for people who are being served in public behavioral health settings, where, according to one study, as few as 29% of people at community mental health had a combined, reliable, and clinically significant change rate. That means that nearly 70% of these people seeking services were not helped. So we have to look at why this might be the case, especially for people who represent these populations that are in non-dominant groups in our particular society. And I think to do this, we can look at our field, the history of our field. and see that there are biases that are based on traditional Eurocentric therapeutic interventions and models. And these were designed by a small proportion of the world's population, which happens to be white, male, and middle-class persons. The typical dyad in psychotherapy historically was a white middle-aged woman who was treated by a white middle-class therapist. And these Eurocentric models just may not be effective in working with diverse populations, and in fact may also do harm by mislabeling and using inappropriate treatment. So what is this sort of Eurocentric paradigm? And essentially it is based on a coded ritual that is medically based, meaning that we do a diagnosis or an expert assessment, which then gives out what the treatment will be that the patient is required to do in order to be cured. So this leads us to a way of thinking and working that simply doesn't match the reality of a global society, including it means it creates a lack of cultural sensitivity of therapists, and this has been backed up by the work of many people who have examined this, the distrust of services by racial and ethnic clients, and in fact can lead to therapy being used as an oppressive instrument by those in power to mistreat large groups of people. And now, just as an example of this, you just need to look at the treatment of North American First Peoples who were taken from their homes, away from their families. They were deprived of their language, traditions, dress, and rituals, and then found to be mentally deficient when they succumbed to alcoholism, suicide, depression, and a host of psychological and physical symptoms. We can also look at the history, for example, of the treatment of those who were suffering from severe psychotic type symptoms. The infamous lobotomy was considered to be state of the art, and this was a routine procedure in the 40s. As many as 18,000 were done during that time. And interestingly, it was applied to what were called difficult patients. These were not the most hopeless cases, but instead patients considered to be troublemakers and that were hard to calm. So in fact, you know, this was such an esteemed procedure that the founder of the procedure, Moniz, received the Nobel Prize for medicine and for pioneering it. So we can also look at electroconvulsive therapy, better known as shock treatment. And this is a procedure that's still promoted today, even for youth. Ernest Hemingway is a prime example. He's a famous American author, fell victim to this procedure during a prolonged bout with depression, and I think his words say it the best. Well, what is the sense of ruining my head and erasing my memory, which is my capital, and putting me out of business? It was a brilliant cure, but we lost the patient. But times have changed. We are now in a new, more enlightened era, presumably. At least that is what the talk is. And when I use the term talk, I mean press, media, website content, and a lot of what is written about and presented at conferences throughout North America. For example, we can look at the Surgeon General's 2010 report that said that to be effective, the diagnosis and treatment of mental illness must be tailored to all characteristics that shape a person's image and identity. And the consequences of not understanding these influences can be profoundly deleterious. And we can also look at the recovery movement and articulated in the President's New Freedom Commission. And for the first time, there is a public pronouncement that recovery is possible, if not expected. And then a little bit closer to home in psychology, we can look at the American Psychological Association Presidential Task Force on Evidence-Based Practice that defined evidence-based practice as the integration of the best available research with clinical expertise in the context of client characteristics, culture, and preferences. So if we take this apart a little bit more carefully, we can look at this notion of clinical expertise that this definition puts forward, and we can see that the clinician is given the leeway to fit the approach to the client and to make changes as needed during the course of treatment. And the therapist's clinical judgment is always at play, and his or her autonomy is valued, and individualized treatment decisions are valued. The next part of the definition, the context of patient characteristics and culture and preferences. Research informs what options are available. However, the client's preferences determine the approach. So this, in essence, is a collaborative enterprise where the patient and the clinicians negotiate ways of working together and where patient values and preferences are a central component. But is this what practice in everyday settings looks like? Do we walk the talk? And I suggest to you that in many ways, practice today follows a familiar script, not much different than what was practiced 100 years ago. Clinicians, in many instances, are considered no more than technicians or treatment delivery systems, not unlike a doctor handing a prescription to a patient. And this is in large part due to the focus on manuals and the requirement that therapists be consistent with the manual to produce the best outcome. Clinical judgment is not a factor here. Therapist training is all about learning the techniques and delivering them in the correct order and in the correct way. And in fact, there are systems that monitor compliance to manuals in many agency settings and that exert control over the compliance to these particular procedures. Assessment is being, sort of coming down to this click by numbers. I'm sure that many of you have seen or you're currently using electronic health record systems. And while there are certainly some worthwhile aspects of these systems, for example, streamlining data management and data collection, they also can confine the work by automatically creating a limited set of choices and language for understanding and addressing the problems that people present. So where does this leave clients? Clients, in essence, can become the label. Their evolving and their moment-to-moment participation is not that important and not utilized except as clinicians try to motivate them to be open to the cure that has been already determined and for them to receive the cure. And it's sort of like they become these cardboard cutouts on which the diagnosis and the empirically supported treatment has been pinned. So the treatment also in these health record systems is derived from a drop-down menu option. Essentially, it's checked off by the clinician, and there's no room to think or explore outside of the menu, or develop a treatment plan that is constructed collaboratively with the client that might include things that aren't on there. For example, the client will get up and shave 3 times a week, or the client will write a love letter to her mother. Now, I'm not saying that many of you may not be developing these goals with your clients, but in all honesty, in many places, these are being done outside the normal procedures of your clinic. They are what you're doing privately with your client. So we've got this sort of dual deceptive system that is being set up. So what we're looking at here is that treatment here promotes adjustment. It promotes adjustment to the label. Clients internalized therapist-defined assessments and diagnoses. And their relationships with themselves and with their significant interpersonal relationships are shaped by professionally defined identities. And the role of social biases and conditions have no room in this model. So these biases encourage our clients to adjust to, for example, power and economic disparities in society, to norms about sexuality, about what a family should be, and to problematic adaptation to problematic societal institutions. So, for example, in an overcrowded classroom, we wonder why children are having problems with attention, and why teachers are struggling today. These are not looked at with our current system of treatment. And essentially, it obscures conditions of poverty, discrimination, and injustice that actually produce these unacceptable or deviant behaviors. So what is the impact of these types of systems on the therapeutic relationship, which we know is the bedrock of effective psychotherapy? And I'm going to suggest that diagnosis has a constraining and a containing impact on the therapeutic relationship, that it separates us from our clients and from their stories. And at the same time, it separates us from their cultural and their healing resources. So I believe there is a detrimental impact on the therapy relationship as we become more automated by this coded ritual of the medical script. And at the same time, we become susceptible to media-touted interventions. Now, there is a dark side to much of what we hear and we learn from the media, often without realizing it. It's like what Martin Luther King Jr. called a shadow, and so this is sort of lurking out there. Now, we have all seen these ads, and we know they're ads, and we oftentimes will laugh at them, but I can assure you the pharmaceutical companies would not be spending billions of dollars on these ads unless they were effective in promoting their bottom line. And these are promising a new day for people, for our clients, and whether we are aware of it or not, and whether our clients are aware of it or not, we are susceptible to these type of corporate profiteering influences. It also leads to an increasing medicalization of expected, and dare I say normal, responses to life experiences and life development. For example, we medicalize combat veterans' experiences when they return back from combat and are suffering from the psychological impact of what they experienced during their time at war. It medicalizes childhood. Children are like the canary in the coal mine right now, and often are acting out in response to societal pressures in both their schools and their homes. And it also can lead to medicalizing diverse expressions of sexuality and sexual identity, although that has been corrected somewhat in the DSM-5, it still lingers. And certainly when we look at treatment of the poor, so-called treatment of the poor, it often, again, involves a diagnosis and some type of medical treatment. And the words of this woman are very illustrative of this. She says, "I am not mental. You can see that. I don't understand why my son left. I want my boy back. I'm not incompetent. Life can make you incompetent if there's no roof over your head. It can make you depressed." Now, I experienced many situations similar to this during my work in family preservation services, and I interacted with larger systems of care. And these systems were filled with dedicated workers doing sometimes an impossible job, and I have nothing but admiration for what they did and still do. And having said that, The system itself often takes on a life of its own, a culture that may talk about poverty but intervenes in punitive and individually pathologizing ways, often removing children from families that could be better served with the provision of resources. And we can look at poor children who are the target of powerful and invasive treatment. 4 times the rate of use of antipsychotics for children than under Medicaid than those in the private sector. Many incarcerated youth are getting potent drugs for diagnoses of things like intermittent explosive or oppositional defiance and attention deficit hyperactivity disorders. More than a quarter of the prescriptions are written for youth who have no diagnosis. So they're clearly a control mechanism for these youth. So what is the impact on these children that already have 2 strikes against them? And Eduardo gives a good example here. He says, it kept me from doing my work. I was always falling asleep. I couldn't stay up for a little bit or even to finish a test, so I kept getting held back in school. So this is occurring in a society where income inequality is increasing and the class mobility is decreasing. Children who are being treated in this way are less likely to succeed academically and socially. They're less likely to move out of the underclass into middle-class jobs. And essentially what we're doing here with our so-called systems of care is perpetuating this cycle. Of course, we can look at treatment of people who are diagnosed with severely and persistently mental illness. These folks are told that they must continue prescription every day of their lives for the rest of their lives. If they don't, they are often forcibly drugged in hospital settings, and they are restrained, not much different than it was 100 years ago or 80 years ago. And what this leads to for them is a sense of hopelessness, a sense of dependency, and of course isolation and stigmatization. Now, I know that what I've been talking about here in no way represents the values that everyone participating here holds close to their hearts. The question is, how can we adhere to our values in a system that does not support these values? I hope to make the case that this requires breaking our silence and it requires action. But let's put this into context of the evolution of our field, because what I'm going to propose represents, in my opinion, a brand new paradigm. So we can look at the our field moving from psychoanalysis to behaviorism into humanism, and then what is considered the 4th evolutionary force in psychotherapy, which is multiculturalism, and has been called, in fact, in counseling psychology, the field's core identity. Disparities in power and recognition of the potential for oppression has led to a real emphasis in this way of thinking and working, and a lot of training at sites of service delivery. But when we look at this, we can see that this training in multiculturalism and critical consciousness may not actually translate into changed behaviors, into actually the therapist's behaviors with their clients. And there doesn't seem to be a single study that looks at the relationship of multicultural training and counseling with clinical outcomes. Furthermore, standard views of multiculturalism do not address key dimensions of social justice, and that is the need to alter conditions that maintain psychological distress may not be viewed as part of the therapist's role. Essentially, all 4 approaches, in my opinion, continue to be embedded in the medical model, which includes this infrastructure of the policies, the procedures, and the paperwork of the institutions within which we work. So I'm going to suggest that the basis for a new paradigm is client voice and choice. And multicultural psychotherapy is embedded in humanism, and it does foster people's capacity for choice, freedom, and transformation. So therefore, we are taking the initiative and the multicultural emphasis, and we're just taking it to another level. So this has to do with client self-determinism, and that social injustice involves the promotion of the values of self-development and self-determination for everyone. Now, there's two ways to look at this. One is psychotherapy and social activism. We as therapists need to be involved in changing social institutions, political and economic systems, and government structures that perpetuate unfair practices, structures, and policies in terms of accessibility, resource distribution, and human rights. We hear the stories of our clients. If we sit on those, we do not work for change, then we are, in essence, supporting those. And sometimes it does mean going shoulder to shoulder with others to protest the conditions that produce much of the distress that we see on a daily basis. So to be silent is to be complicit in hiding these resources. But it also means something else. It means the work that we do every day with our clients. And this is the insight that the feminist movement had, that the personal is the political. The small, everyday things that we do in psychotherapy constitute political acts. What we do in our daily practice within the sphere of psychotherapy talk or within the confines of our work setting either supports or undermines systems of injustice and oppression. Transforming these mental health policies, procedures, and paperwork to give clients the loudest voice in determining goals and methods for therapy is a political action. And that's where PCOMS comes in. The Partners for Change Outcome Management System is designed specifically to systematically include clients' voices to guide all treatment decisions. Clients teach clinicians their desired ways of working and their preferred outcomes. Using PCOMS is walking the talk. It provides a safety net for ensuring that we do not replicate the oppressive practices of the past and continuing into the present, especially when we're working with clients who differ with us along lines of culture, ethnicity, race, gender, social location, and other aspects of identity. So this is PCOMS as just talk. Clients' worldviews and beliefs are integrated into treatment decisions and serve as catalysts for change. It's a continuous process of exploration of client meanings and stories that allows for a contextual view of the strengths and barriers inherent in the social and physical conditions of clients' lives. And I'm showing you here what is called the circle. It is a native tradition, according to John Peters, Slow Turtle of the Wampanoag tribe here in Rhode Island. It is a native tradition to sit in a circle and talk to share what is in your heart. So it allows for us as therapists to adapt our way of working to the clients that we are working with. Just Talk is a blueprint for political action. It amplifies the voice of clients and communities to counter the silencing effects of oppression, poverty, and discrimination. It paves the way for clients to have a greater voice in their communities to bring about social changes they desire. And it involves this examination and evaluation of all the paperwork to bring in line with a systematic collection of client feedback and the incorporation of client feedback into all supervision and staff meetings. So what can we do? Just Talk as political action means advocacy and education at larger policy levels to transform payment systems based on diagnosis to payment systems that utilize client feedback. It requires advocacy for the creation of flexible services, for example, home-based, community and school-based, so that we can be more able to honor client requests for non-traditional forms of help. And these are actions that are small that you can take as well as large. Small actions such as speaking up in staffings and in supervision to bring the client's voice to the center of the conversation, or to advocate for adopting PCOMs. Instead of diagnosis, use client scores on the scale to change the conversation and center clients' voices. And then larger actions are to create community. Together, we can have the most power to affect change in our agencies and our work sites. So you can't be neutral. This is what Howard Zinn says. You can't be neutral on a moving train. You know, the train has already left the station, and if you're just standing still, it's going to take you down that road, and it may be a road that you are not where you don't want to be. So again, in closing, the words of Martin Luther King Jr., we must never adjust ourselves to racial discrimination and racial segregation, never adjust ourselves to religious bigotry or to economic conditions that take necessities from the many to give luxuries to the few. We must never adjust ourselves to the madness of militarism and the self-defeating effects of physical violence. In closing, this is about what we do every day in the privacy of our offices, in our conversations with our clients and coworkers, and who we are as citizens. It is about the social order and our role in conforming or not conforming to inequities, or resisting them, and in resisting them, offering alternatives for a more just society. And I believe that in solidarity, we can make this happen. So thank you all for listening to this. And at this time, if we have time, I'm open to any comments or questions that you might have.
All right. Well, thank you, Jacqueline, so much. That was very inspiring. And I'm just grateful that you were able to present this for us today.
Yes.
And now, Jacqueline, if you can hear me okay,
yes, I can.
I'll start reading some of the questions. If anyone else wants to ask Jackie a question, please enter it now. So here's a good one. What advice would you give to folks working in agencies that require diagnosis and have to do it as part of their jobs?
Well, I hear this a lot, Cindy, and this is a real bind for clinicians in the field today. I mean, when I do this talk and I talk to my students about that, they say, that's fine. I mean, I want to do this, but I have to put a diagnosis down. If we don't put a diagnosis down, we don't get paid. Essentially, this is a catch-22 in our system. The whole system hinges on what I had described as this medical-based approach, and diagnosis is the centerpiece to that. What I recommend, I made some suggestions in this talk. First of all, the small ways that I talked about was to, in your conversations at your agency, that you encourage the use of PCOMs so that you can center the client's voice. You use PCOMs yourself, and then in supervision and in staffing, when people are talking about the diagnosis, you can gently come back to, the client shows me that she is improving here, and here's on a valid instrument. And when I asked her why she was up 5 points on this instrument, she began to talk to me about this. So you can see that that's steering in a different direction than the diagnosis types of conversation. But this is not enough. I think that clinicians need to connect with others who really want to fundamentally alter business as usual in psychotherapy, so that you're not having to be, the diagnosis system is not ruling, everything that we do, and it does impact everything that we do. So I think that requires a larger effort, and it means joining with other people, like go to heartandsoulofchange.com and become part of the project there. There are other organizations that you can look at that will be helpful that are trying to challenge this centrality of diagnosis. But I really do think that we don't want to replace diagnosis with just another system that essentially does not transform the medically based approach that I've been talking about, that it's just a sort of first order change versus the second order change. I really think that requires the ongoing routine collection and utilization of client feedback at every meeting with your clients. Only then are we going to be able to move in a different direction. But I want to say that with all recognition of the dilemma that clinicians face in their work site. But we can't give up hope. If you believe in this, then you need to take action. And like I said, I've made some suggestions on how to do that.
Okay, here's another one, kind of along the same lines as the last one. What can be done to change psychotherapy from an expert diagnosis-based system to one that truly privileges and puts the client's voice first?
Well, it is along the same lines, Cindy, because I believe it does involve the use of diagnosis. And, until we have third-party payers interested in the fact that our diagnostic systems are not valid or reliable, are not going to be the best gauge of improvement. In fact, they're more likely to have clients become mired in a sort of lengthy process, costing more money, and if you look at many of the side effects of, for example, the medications that are being given to people for so many diagnoses, and if you are really aware of what those side effects are, you can recognize that there are these iatrogenic effects that just compound the difficulty. And I think Robert Whitaker makes this point that in his book, that The Anatomy of an Epidemic, that if these drugs were the miracle cures, depression would have, sort of gone down to a minuscule percentage at this point. But we don't, anxiety would be resolved. These drugs are not decreasing one bit the incidence of these problems that people are having. In fact, these problems continue to expand, and you have to wonder whether the treatments that we're giving people, in fact, are making people worse. So I think that we really do need to work with third-party payers about, they're interested in the bottom line. Many of them may be humanists. I'm not saying they aren't, but I think their job is to have the best treatment outcome for the least amount expenditure of capital resources. I think we need to do a better job articulating that case to them. And so I see that as the biggest obstacle right now.
All right, well, most of these questions are kind of similar to that. Here's a request to get the slides. Do you post your slides on SlideShare?
I don't, but I will have them on heartandsoulofchange.com, so they would be available there. So I recommend people go there. That's a one-stop shopping and a really great place to get that sense of community, to look at other presentations on this topic, to join with other people who are on a mission, basically, to transform mental health services as we know it. So if you want a good place to go, I would recommend that as the first stop. And visit it frequently, because the blogs are up to date, and we always keep up to date on what we're doing with the project, what different members of the project are doing in their various sites and agency across the world. So you don't get that sense of isolation and feeling like, oh, I'm in this alone. You really know that there are other people who are doing things, and you get ideas of what you can do. So my slides will be available there.
Thank you, Jacqueline. And if you're not familiar with the Heart and Soul of Change project, don't worry, we will make sure that we send you a link to it when we send you the webinar recording. Thank you everyone for attending, and a big thanks to Dr. Jacqueline Sparks and the rest of the team at the Heart and Soul of Change project for all your hard work and dedication.
Thank you, Cindy. And thanks, everyone.